Hello, I am Dr. Sathish, specialist pediatrician working in eye care clinic under Emirates Healthcare Group in Oasis Center. Today's topic is short stature. 2.5% of population are short. When the children are brought for evaluation, first decide whether child is really short or not. Short stature is defined as height less than 2 standard deviation for age and sex. Target height more than 2 standard deviation below the mid-parental height. Height velocity less than 25th percentile for more than 6 months and or downward crossing of percentile on growth chart after 18 months of age. If the child is really short, verify the age by asking for date of birth. Evaluation of short stature start from antenatal history of maternal infections, drug intake and alcohol abuse in the mother. Then find out birth weight, length, head circumference and gestational age. History of neonatal hypoglycemia, neonatal jaundice and microcephalus and hypotonia. 80% of small for gestational age babies catch up by 2 years. Delayed development, if any, points towards syndromes like Down syndrome, Prader-Willi syndrome, Turner syndrome, Russell-Silver syndrome, etc. Accurate calculation of dietary intake of protein, calorie, vitamin and minerals are important. Family history of consanguinity, late bloomers in the family, parental height, short family members are to be ruled out. Ask about the onset of puberty in parents. Systemic disease should be ruled out. Inquire about socioeconomic status like parental devotion, medication history like steroids. Psychosocial cause also should be ruled out. Then measure accurately the length in infants up to 2 years of age by infantometer, height later by stadiometer. Then compare with population norms using growth chart. Plot in WHO growth chart up to 5 years or use IAP growth charts. If the child is growing parallel to third centile, monitor growth velocity by serial measurements of height. All growth velocity should be corroborated with sexual maturity rating. If the child is obviously short, need not wait for growth velocity measurement. Straight away do complete workup. Then calculate child's growth potential to find out whether it is familial or constitutional delay by using the mid-parental height and target height. Target height, mid-parental height for boys is obtained by adding 6.5 cm to the average height of child's parents and for girls by subtracting 6.5 cm from the average height of her parents. Target height is 8 cm above or below this. Measurement of body proportions, upper segment by lower segment ratio is important in case of skeletal dysplasia. Upper segment is calculated by taking the height and subtracting the lower segment obtained by measuring from symphysis pubis to the floor from the height. Upper segment by lower segment at birth is 1.7 and at 3 years 1.3, 6 years 1.1 and adult it is 0.9. Upper segment by lower segment ratio is more in ricket, achondroplasia and hypothyroidism. In condition affecting the spine, the ratio is decreased. Arm span is shorter than height in boys before 10 to 11 years and girls before 11 to 14 years, after which it exceeds the height. In short, short stature could be physiological like familial and constitutional delay in growth and puberty, or pathological. In pathological, is dysmorphic features present? See whether it is proportionate or not. If proportionate indicates Down syndrome, Turner syndrome, Russell-Silver syndrome, Noonan syndrome, Prader-Willi syndrome, and DiGeorge syndrome. Disproportionate short stature are due to either short limb or short trunk. Short limb causes are achondroplasia, hypochondroplasia, metaphyseal chondroplasia, refractory ricket, and chronic hypothyroidism. Short trunk are mucopolysaccharide, mucolipidosis, caries spine, and hemivertebra. If no dysmorphism, look for weight for height. If increased weight for height, it indicates Cushing syndrome, hypothyroidism, growth hormone deficiency, or growth hormone insensitivity like Laron syndrome. If weight for height is decreased or normal, indicates chronic malnutrition due to celiac disease, cystic fibrosis, psychosocial deprivation, or eating disorders like anorexia nervosa. Coming to examination, look for dysmorphic features of Down syndrome, Turner syndrome, Russell-Silver syndrome, Prader-Willi syndrome, DiGeorge syndrome, Noonan syndrome, or growth hormone deficiency. Look for midline defects, Cushingoid features, immature facies, cold dry skin, lymphedema, blue sclera, unexplained injuries, body proportions, joint swelling, wasting, like that. Assess pubertal status by sexual maturity rating using Tanner scale. Born age is very important for assessing growth potential in a very early years. Born age is calculated by counting the carpal bones in early years and afterwards by comparing with the standard charts of Grewley and Piley. Adult height is prediction is based on the born age. Born age of 14 in girls and 16 in boys marks the end of growth. Lab tests like complete blood count, ESR, peripheral smear, calcium profile, thyroid function test, karyotyping, liver function test, kidney function test, cortisol estimation should be done. No role for random growth hormone estimation. It is produced in deep sleep and does not stay more than 20 minutes in the circulation. So, do growth hormone stimulation test either pharmacological stimulation with clonidine, arginine, insulin-induced hypoglycemia, or glucagon, or physiological stimulation during sleep or after exercise. Need multiple sampling to catch at least one peak value. 10 or more is normal. 5 to 10 is partial defect. Below 5 is abnormal. MRI brain and skeletal survey also are useful. Treatment of short stature is according to the causes. First, determine if the condition is treatable and presented in time. Only 5% of short statures are due to endocrine deficiency, out of which half only due to growth hormone deficiency. 1 in 40 cases of short statures are due to growth hormone deficiency. If there is growth hormone deficiency, you can start growth hormone treatment in the newborn period itself if baby presented with hypoglycemia. For small for gestational age, you can start growth hormone by 2 years of age if no catch up, or you can wait till 4 years. In the Turner, start growth hormone treatment as soon as slow growth velocity is noticed. Otherwise, you can wait till 6 to 7 years of age as the treatment is very expensive. Other indication for growth hormone treatment are chronic kidney disease, Prader-Willi syndrome, and Sachs haploinsufficiency. Skeletal dysplasias Down syndrome, metabolic disease, cystic fibrosis are not approved for growth hormone treatment. Dose of growth hormone is 0.025 to 0.05 milligram per kilogram per day, subcutaneous, given daily evening. Continue till 14 years in girls and 16 years in boys. Monitor IGF-1 for compliance, safety and titration. Younger the child, shorter the child, smaller the child, the better is the outcome. Treat till they reach adult height or complete fusion of epiphysis. If the child is late and not treatable, give reassurance. Height is very important factor in personality. Find out the cause of short stature early and treat so that your child could not blame you later. Thank you.